Hi, Owen here, going to talk about the IPV device and how we use it at St. Alphonsus Regional Medical Center in Boise. Wearing my mask to keep you safe from COVID. Anywho, so this is an invention by Dr. Bird. We use it as the third tier of our lung expansion protocol here at St. Alphonsus. Pretty straightforward in how it's set up. The tubing itself comes in a package that looks like this. The devices are stored in our central supply area. We usually don't keep them on the various floors, so you're going to have to take it up to the floors in order to use the device, and then you leave it in the patient's room, of course. There are three setups or three pressure lines on the device, and they're color matched here. One is your gauge, which runs this. One is your phasotron, which is the pulsatile piston that allows entrainment. Remember, the faster it goes, the less oxygen it entrains, or the less air it entrains, so your oxygen blend is higher. The slower it goes, the more air it entrains, and your oxygen blend is lower. Then you have the aerosol. So on the aerosol itself, we typically run a 10-minute treatment with IPV here. You need about a cc per minute to allow enough hydration in the airway. Otherwise, this is a pretty drying procedure for the patient. The pressure lines snap in. Just like that. The device looks like this. This can be manipulated and you can change it, so we can adapt it, place it onto a mechanically ventilated patient or a trach patient. This would just hook into the suction limb. But the majority of these are patients who are able to use a mouthpiece, so it looks like this. So you have your pressure line here. You have your phasotron line here, it's in white. And you have your nebulizer line right here, it's in yellow. The filter is beneficial because a lot of output of aerosol. You may need to check this once per shift because it gets pretty full, pretty saturated. The device turns on, we're pressurized, oxygen's your only option. A couple of things happen. We notice this pressure gauge right here is at 20 psi. It's in psi, it's not in centimeters of water pressure. Once the patient starts breathing on it, we can see that gauge up there starts moving, and we read what the pressure is, and it is in centimeters of water pressure. The driving pressure, as we call it here, is adjustable. We usually set it at about 20 psi, and we can go up or go down based on the patient. What we really want to look for is chest wiggle. So when the patient's breathing on that, are we seeing the percussions in the chest wall? The percussion itself, you can set it one of two ways. The slower helps with secretion mobilization, and the faster helps with collateral expansion. So it really depends on what you're trying to do with your patient. As you can see, as they turn it more to the right, it goes slower, thus mobilizing secretions. And as I turn it to the left, it goes faster. And they're varying speeds. So the folks from Bird will tell you it's about 100 when it's all the way here, and up to 300 beats when it's all the way to the left. One of the things that sometimes throws folks if the operational pressure, driving pressure is turned all the way down, you won't see any movement whatsoever. Just know that you can turn it up. And the device is not broken. It's just the pressure's been turned down all the way. So I hope you enjoyed this. It is a device we use not frequently, but will, depending on our patient's condition and how they work through the lung expansion protocol. I hope you found this helpful. Thanks for watching.